Okay, we better get you started.
Bill?
Does he want to
Yes.
Okay. So, my presentation is on the effects of amphetamine on the recovery of function in motor conditions. So, this is important because, well, starting in the 80s, it was wondered if amphetamine was going to be a useful treatment for stroke patients. And since then, it's been the most studied drug about its use to help people with stroke. So, over 30 studies have been done since the 1980s, which have been reviewed recently. So, very briefly, background. Amphetamine has two isomers, and the one which is more potent is the dextroamphetamine. Right now, one of its pharmaceutical names is dexedrine or Adderall. It affects on the level of the neuron by preventing reuptake of norepinephrine and dopamine back into the synapse. And on a very small level, it also affects serotonin, but in clinical doses, it's so small it's pretty much negligible. So, the big picture is we're trying to help people with stroke patients, and so all of the studies, the construct is going to be around stroke patients. And so, the leading deficit with people who have stroke is that they have motor impairments. And so this is going to reflect that. All of the studies that you're going to be seeing are going to be dealing with motor impairments. So the first question is, does amphetamine have an effect at all? It would be kind of pointless to continue if it didn't do anything. So the first paper that we're going to look at was Adkins. And they were asking that very question, is it better than nothing? And is there any longevity in the improvements that are seen? So in this experiment, they had the rats, they removed the skulls, and then they added some chemical to the sensory motor cortex, which causes vasodilation. So that's going to cut off the blood flow to that part of the brain for the rats. And it was always picked in the side contralateral to the dominant limb. So if the rat wanted to use its right paw mostly, then the left side of the left hemisphere would be reaching. All of the rats in this experiment were male rats, and this was done at the University of Texas. So what these rats were tested on was a reaching task, where they would have a colorless window which they would reach through and grasp at a food pellet. And this is to model a fine motor skill that stroke patients also have to do, because there's a lot of fine motor manual tasks that we have to go through. And then some groups were given amphetamine and some not. Now, this graph has a lot of information in it, so I'll just give you a few seconds to look at it before I explain all the details. Okay, so looking at the legend at the top right, any of these dark colors, this is the days that the treatment were given, either the amphetamine or the saline solution, this nice injection. And then all of the other white days were days of training that they didn't have a drug treatment. All of the circles are the amphetamine groups, and all of the squares are the control groups. So there's a few things to point out here. One, that on the days that the amphetamine groups received the drug, they performed a lot worse than they would on days that they didn't. And so this suggests that the amphetamine is helping, but when a rat's really intoxicated on amphetamine, it doesn't do so well with grasping. The other thing is, as a general trend, the amphetamine group is performing better than the no amphetamine group. And also, as we go on to the far time, there's no real difference between the amphetamine after 60 days or 90 days. So it kind of puts into question if there really is a long effect after the treatment is stopped. One other thing that you don't see in this graph is this is measuring therapy days, not the days after the lesion had taken place. So there was a 10 to 14 days recovery period between the lesion taking place and before they even administer any drug at all. Does anyone need a clarification on anything on this before I move on? Okay, moving on. So, what have we found from this? So, just to recap of what the graph just said. For the first 30 days, the amphetamine group did better than the control group. The amphetamine group did poorly on the days that they were treated, but they did comparatively better on the days that they weren't treated. And also that there was no significant difference between the amphetamine group and the control group after 2 months had passed. But there's some things that this study doesn't account for. Like, for example, there was no histology. We didn't see anything about neuronal change. And they were given a lot of amphetamine. They were given it every 3 days. So that was 7 doses total. And so if we're looking to give people, if we're trying to give stroke victims amphetamine, I don't know, you'd run into addiction problems, I think. So what we did find out, though, is that amphetamine does have an effect, but it was always paired up with rehabilitation, so we want to find out if it's just as good without rehabilitation at all. So that leads us on to the next paper. Is there neuronal growth, and is amphetamine just as good with rehabilitation as it is by itself? So there's no words here for the next few slides. All of the information is also in the handouts I gave you, but I'll just explain it. So these rats were given brain lesions. The scalp was removed. Once again, they were damaged in the motor cortex for the sensory paw, contralateral to whichever was their dominant hand. They were given 2 different training tasks that would use the paw. One is the reaching task, and the other one is this ladder task. So for this, for the reaching task, they were given 5 chances to reach the pallet, and if they didn't get it, then that was their trial. For this ladder task, they're trying to walk along this ladder with these fine steps, and then they're measured for how many slips they make, and it'll be measured for every 10 slips. And so the treatments that the rats got were either they would have amphetamine or no amphetamine, and they could have rehabilitation or no rehabilitation. These are some of the exercises that the rehabilitation rats got. They also got a larger cage and lots of toys to play with in the cage. The purpose of these is to encourage the rats to use the paw that was damaged. Because if you have brain injury to a paw, and you're encouraged to use it more, then that should facilitate some kind of change. So, for the reaching task, the number of pallets that the rats got. So we start here with the control amount, and you'll find that the group that did the best, this green bar, is the group that had the amphetamine and the rehabilitation, and they did a lot better than the other ones. The amphetamine group, which is the red bar, also did quite well, but not as good as when paired up with rehabilitation. And the other 2 groups, they did the worst. So in the ladder run task, similar results. The green, once again, they're doing the best. So in this one, down is good. The lower the score, the better. So starting with the controls, and then the amphetamine group matched up with the rehabilitation, again, did better than all of the other groups. In this one, amphetamine alone, which is the red bar, didn't do any better than the other ones. This is the histology. and kind of makes your eyes cross trying to find what they're talking about. So I gave these nice arrows. In this first one, which is just a lesion by itself, you don't see anything, and that's kind of the point. In this next one, you see we're looking at the number of crossings across this dotted line. There's a little bit, but still not very much. With the amphetamine group, not very much. The one that I want to draw your attention to is these two. They're both the same picture, but one zoomed in of the other. And you see that there's lots of fiber crossings there. And this is at the level of the pontine nucleus, which is in the pons, and it's important for motor function. And these are axons crossing the midline. So for the findings of the second study, amphetamine combined with rehabilitation gives the best effect, and that there is axonal growth in the brain. Okay, so take a deep breath. We're almost over, almost through. So the last study that we're going to be looking at is in primates, in monkeys. So we have added relevance to people. So the reason why we want to look at monkeys is because they are very similar to humans. They metabolize amphetamine similarly to humans, and the cortical representation for their hands and digits is a lot more similar to people than rats are to humans. So in this study, they took squirrel monkeys of both female and male genders, and they separated them into 3 groups. And then they were tested on the Kluver board task, which is just another variant of the reaching task. It's the same thing as what the rats were doing. And in this experiment, they only received one dose of amphetamine at one time. So, here's a picture of the squirrel monkey that we're using this test. So, one word which might trip you up in this is the word flexion. What that means is the grasping action. So, this is a measurement in the reaching task of how many grasps it would take before they got a food pellet. So if it took 3 grasps to try to pick up a pellet, then they would get a score of 3. The amphetamine group is this diamond group at the bottom. And so you see as time goes on, they did better. It would take them less grasps than the other groups. The square group is the control group. Rather, they had the same training as the amphetamine group, but not the amphetamine. And then lastly, the circle group is just, they had the lesion, but no training and no amphetamine. So in the beginning, there was kind of a mix-up of performances, but as time goes on, after about 3 weeks, there became a pretty established pattern that the amphetamine group was doing better. So, conclusion of this study is that the amphetamine paired up with rehabilitation is better than rehabilitation alone, and that this finding is consistent with what was found with the rats. It's true with monkeys as well. So, to recapitulate of all of the findings of the 3 papers, Adkins found that amphetamine does make a difference. Ramick found that amphetamine paired with rehabilitation is better than just amphetamine alone, and that there is histological differences. And then the last paper found that amphetamine does work in primates. So, to go back to the big picture about whether or not we should be giving people amphetamine after they have a stroke, that's kind of it. I think you have to draw your own conclusions from this. It looks promising, and there have been a lot of clinical studies done, and there's mixed results. Some say that there is improvement, some not. But after looking at these studies, there is hope. There's a few things that these papers didn't address. For one, the time that the drugs administered was very different in all of them. In the first one, they didn't receive drug treatment until 2 weeks after. In the second one, also, I think it was the same. Sure. But the point is, we don't know from these studies if improvement would have been better if they were given a dose of amphetamine on the very day that they had the lesion. And in clinical stroke cases, it's very common that people won't have a drug intervention until about a month after they have their accident. Another thing this doesn't account for is the dose effects. That is, I didn't say it because it's kind of fine detail, but the monkeys received a very, very small dose of their single dosage of amphetamine. Some of the rats received a lot more, like 4 times as much per body weight as the monkeys did. And so it may be that the behavioral effects would have been different if those were accounted for. And lastly, and most importantly, I think of these things that isn't accounted for, is we're talking about stroke. And usually when a stroke happens, there's a lot of subcortical injury that happens as well as the cortical damage. There is motor deficits, yes, but also on the level of the thalamus and the vagus and ganglia. So that is my presentation. I hope you enjoyed it.
You seem to be running a bit short on time, so I'm not sure that we'll be subjecting you to a barrage of questions.
Okay. Would you like to ask one?
Big pardon?
Would you like to ask one?
No, I'm good.